graph has a lot going on. Basically, all I want you to know is there is this thing called a pharmacy benefit manager. It exists as an intermediary between pharmacies, manufacturers, healthcare organizations. You'll hear things like drug formulary sometimes. Essentially, a PBM has a list of drugs that they contract out to these various organizations. And they tell them, if you use this drug in our patient, we will give you a rebate for it. Okay? That's all I want you to gather from this slide. Now, there is talk about why don't we eliminate the PBM? They are a part of the problem. The issue is we don't know how much. There's not a lot of transparency in this system. So what does this have to do with pricing? So this is kind of what I said. There's actually validity to eliminating, but again, they're kind of like unions. They have a large amount of patients buying in, a lot of healthcare companies contracting with them. So it's difficult to just eliminate them and see what will happen to the free market. We don't really know. Intellectual property. So I have two drugs here, Prilosec, Nexium, omeprazole, and esomeprazole. So when we refer to a drug, so you see up there Prilosec, Nexium, those are brand names of a drug. So you go to a drugstore, that's what you commonly see. You see Tylenol, things like that. Normally, underneath it, in parentheses, you will see the active ingredient in that drug, okay? So Prilosec is omeprazole, Nexium is esomeprazole. Omeprazole first hit market in 1990. Esomeprazole first hit the US market in 2000. Both of them are owned by the same manufacturer. So how do patent laws benefit AstraZeneca with these drugs? So patents for drugs typically last 20 years. And drug manufacturers have exclusivity to produce these drugs to patients. This is kind of chemistry related, but if you imagine your left and right hand are active ingredients, but only your right hand actually works in the body. So the thing with drugs is there's this concept of mirror images. Drugs are very specific, so there's no way I can orient my right hand to be the exact same as my left hand, right? The only thing that will be the exact same is the mirror image of it. That's essentially what they have with this drug. They have two active ingredients. One of them is only 5% active, the other is 95% active. So what they did was they decided to purify omeprazole to only the active ingredient into esomeprazole. Does that kind of make sense? So they took a 5% difference and just made it 100% of the same thing. And then they ran studies and used too low doses and really high doses of their new drug to show that it was superior. Yeah, they kind of rigged the system on that one. And to this day, Nexium is still one of the most popularly used drugs. Now that original study that they proved it was superior is not cited anymore. There are some reasons why it's more beneficial, but at the time, that's what they did. And you see that with other drugs as well, where they make slight alterations and still charge outrageous amounts. What are some solutions for venting like this? Or patent laws? Allow patents to expire sooner, have more stringent guidelines, improve transparency, prevent drugs from being expedited. Drugs from being expedited, you look at things such as Ebola virus. In recent years, it's huge. The drugs, like those, were fast-tracked. It only took maybe 3 to 5 years to put them on the market. So that's an issue right there by itself because we rewarded, it's not really rewarded. We had a need for something, we created a drug for it. That's not the problem. The problem is that after they created that drug, they had the exclusive rights to make that drug and charge any amount they want, essentially. There is a silly law with Medicare. So Medicare Part D is voluntary insurance for prescription drugs on Medicare that was proposed by Bush, and we came along in 2003. remember, Medicare is a public sector of healthcare. Because of how the law was written, Medicare is not allowed to negotiate drug prices, where private insurance companies are. This means drug companies can set whatever price they want and the government will pay it. This should be an easy fix, and it was one of Obama's main running points, but it was overlooked during his presidency. President Trump has fixed that, or well, not fixed it. He has said he's going to fix it. We'll see if he actually does. He said it so far, I think 3 times. The November 3rd article on The Economist just talked about it. We'll see if it actually happens. Was it nice to meet you, Gloria? A lot of times if you ask any questions to a professor, they're just going to tell you what the syllabus. Convenience, cost. You may have seen this if you're on Instagram. This is Kim Kardashian and diclejus. So diclejus is a drug made up of pyridoxine and doxylamine. I don't expect you to know those. They don't really matter. Just know that both of them are used for nausea and vomiting. 30 tablets of pyridoxine, $1.91. 30 tablets of doxylamine, $3.95. Putting them together in diclejus, $208.64. So is diclejus better? Only if you want to take pills that cost 109 times pyridoxine and 53 times doxylamine. You get the same thing for about $6 if you're willing to take them separately. Now, doctors often receive kickbacks for these drugs, or benefits, or rewards. Manufacturers will give them samples of their drugs just to promote these drugs as superior. Now that's a part of the problem. There's not really a lot that's been done to prevent that. And there's not even really been a lot of solutions to prevent that either, which is kind of scary.
So a couple questions with this. Why so much more expensive for the combination? And if a person is prescribed this, what course of action do we as the public have to advocate for ourselves to ask and then find out if there's a way that it could be given the same impact and effect in a different, like, prescription, so to speak?
So the reason it costs so much that you'll frequently hear is innovation. Innovation is expensive, but it's hard to put a price on innovation. Now, in this case, not the greatest. We'll talk, well, there are innovative things such as different delivery systems for drugs, whether you want an injection, whether you want a tablet, things like that. So that's a big factor about why drug prices cost what they do. Now this, all it essentially did was combine them. There wasn't a lot of innovation here. They just put the drugs together and said, we're going to sell this to you.
So you're paying all that difference just so you have the ease of use of one tablet versus two?
Yes.
How do you feel about like reducing or eliminating intellectual patents if stuff like this doesn't happen and anyone can produce like a competitive like medicine or product?
I don't think it's a good idea to eliminate patent laws. They do have a lot of benefits, and it's not necessarily a bad thing that manufacturers have exclusive rights to produce their drugs. It's more the amount of time they have to produce them, or what happens when they know a generic is about to reach market. They will purposefully do things to prevent that generic from reaching the market like it should. Does that kind of make sense?
Yeah.
So it costs a lot of money to research and develop drugs, right? Well, it depends a lot on the drug that you're researching, but I just want you to look at how much is used just to market the drug. So we see about 27 billion if we add up the categories. Clinical trials, the actual research phase is a very small sliver of actual cost for the drug itself. It's the marketing. And that's the TV ads, the YouTube ads you see. Manufacturers set drug prices. Typically when a drug is brought to market, it's given a specified price. It's largely unknown how they decide. They will say innovation is expensive. There are some ways pharmacists and doctors avoid these outrageous costs. do that through clinical guidelines. So a clinical guideline is essentially a patient gets a diagnosis, they would go to a pharmacy, a drug specialist, who would look at these guidelines and say, what's the most cost effective to treat this patient? Keeping in mind that they have limited income or limited resources for a drug. Okay? And they serve as a stepwise approach. So we try to use the drug that's least expensive, that has the most benefit towards patients. One of the issues with clinical guidelines is it doesn't take into account the other drugs on the market or the insurance that individual's patient has. You may have seen Martin Shkreli. He was in, yeah, that's what they call him, Farmer Bro. So, what did he do? He took Daraprim, an old anti-malarial drug from the 1950s. It's no longer used for malaria. In 2015, he bought it and increased the price from $13.50 to $750. I guess the question is, why did it matter? We don't even use it for malaria anymore. Nobody liked him. If you look up on YouTube his congressional hearings, he was a smart aleck, he laughed, he didn't care to answer questions. He really didn't care. He just wanted that money, and he was very clear about it. Now, it's not used for malaria, but it does help prevent complications in immunocompromised patients, and because it's an older drug, it was very cheap compared to alternatives, which is why people were so angry. Because the next closest drug, I think, is almost doubled in price to its original $13.50. Now, even today, it is still $750. So nothing has been done about that. But he has stated that he will try to contract with hospitals to deliver a cheaper price specifically to them. We'll see. Manufacturers prevent generics from reaching the market. Money makes the world go round. Branded generic drug manufacturers prevent competition, convincing generic companies to sign pay-for-delay agreements. They also encourage citizen petitions. These are concerns that the FDA is required to prioritize over the generic. And a lot of times, these aren't directly by the manufacturer, but the manufacturer will pay a safety organization to put in claims against a drug, a new drug coming on the market that's a generic of their own. Manufacturers can create and market a drug, a generic of their own, such as the case with the Nexium and Prilosec. It was essentially the same drug. Now the thing with generics is they have to be equivalent to the brand drug. So one thing that they commonly do to prove equivalency, so to prove equivalency, you need that brand drug. You need to prove that it has the same, we'll say, biology and chemistry, structure, and it has to have the same proven effect within the body. So a lot of times what they'll do is they'll say, okay, we're not going to produce our drug for the next 3 months. We're going to put it on back order. So then these generic companies can't get a hold of it. And if generic companies try and obtain it, they will just send a letter to them from the FDA saying, we have no obligation to give you this drug. And they would rather that their drug be on back order and not used than for their drug to actually have a use in the market. You'll see things like this a lot. There are some classes where I've sat there and they'll stand there doing a math equation for the entire class period, and I'm supposed to understand how they got to a solution. Economics of drugs. So there are some principles for the economics of drugs. To an extent, standard demand and supply principles apply. There exist monopolies because there is no single manufacturer, there are no exact substitutes, guarantee of no competitors via patent protection, so they essentially have a monopoly on their drug. The FDA prevents drugs from entering the market as quickly as they should. And insurance actually plays a role, which I'll talk about in another slide. There is asymmetric information. So a lot of times for patients on Medicare and Medicaid who may not necessarily be able to afford a drug, that manufacturer will say, okay, I will give you this drug, but you have to provide me data on every single patient. And they own the exclusive rights to that data. That may not be much for the patient because they're essentially getting a drug that they need, but they have no access to that data whatsoever. And we don't know what that data is being used for, why it's being used, things like that. And then there are also short-term shocks that occur. So supply-demand curves depend on the drugs. It also depends how much the patients really feel different from normal when taking the drug. So things such as, like on the left here, blood pressure medication. Some of you may be sitting in this room and have high blood pressure, but it's not something you actively feel. You don't necessarily know until you go to the doctor and they tell you, okay, your blood pressure is elevated. But maybe something such as pain, you know you have pain. You're going to want to take a medication for your pain, especially if you're getting no relief from doing normal activities or taking something over the counter. How does insurance influence demand? So I put up here price 1 and quantity 1, demand with no insurance. Price 2 and quantity 2 would represent demand with insurance coverage. So it does increase the demand, but a lot of that's because the patients themselves aren't feeling as much of the cost for that drug. It's been covered by someone else in addition to themselves. But what about when we increase the percent of coverage? So imagine demand curve 2 is 20% increase in insurance coverage. But we see it's a much steeper slope. What about 100%? You can see that'd be perfectly inelastic. So, yeah.
No, just the vertical.
Oh, I thought you were
No,
serious.
no, I'm like talking through the elasticity of the curve.
Side note, addiction does the same thing as this insurance chart. So addiction runs on a spectrum. It's not just one day you're addicted. You slowly become addicted over time to almost every medication. There are some specific exceptions, but hopefully you never come in contact with these drugs. Yeah.
So if a greater increase in coverage increases the inelasticity, wouldn't that hypothetically make it easier for like the Martin Shkreli's of the world to hike up price?
It does. That's part of the problem.
So we don't want anyone to have insurance.
It's not that we don't want to have insurance. It's just people like Martin Shkreli take an old drug. So the Daraprim case, because it was on formulary, because it was such an old drug, and it was so cost effective for its use. So what happened right after he raised that drug, almost all insurance providers took that drug off. They would no longer provide coverage. So patients were essentially paying that out of pocket completely. No one wants to pay $750 for a drug. And that was just for a dose. So we want them to have insurance. It's just a matter of how much insurance. So some price ceiling issues. There are some harmful and beneficial cases. Other countries do utilize them. In the US, it depends on the drug, the patient age, and the medical condition it's being used for. The elderly over 65 are especially vulnerable. What do you guys think this might be? So those over 65, typically they're more frail. They're on average, let's see, 76% of patients greater than 65 have 3 or more medications, and about 34% have 8 or more. There's a lot of medical conditions they're managing for elderly patients. And they're also the greatest risk for death, mortality rate issues. So Canada kind of does a price ceiling. The thing with Canada, though, is it has a large organization that's in charge of managing their medications. So what it will do is across the board, they will compare drugs and say, this is the most beneficial drug for the cost. So we will cover this drug. So all Canadians, if they have a medical condition for that drug, will use that drug. Unless, say, they fail the drug doesn't work as effectively, something along those lines, then they will change the drug. But initially, they do everything on a stepwise approach, so you will move in a certain fashion. Remember that some drugs are required to sustain life. If we affect the ability to obtain those drugs, it can be very detrimental in those specific patient populations. And one major benefit of the US is the ability to produce high quality drugs. There's the argument that ceilings may decrease the quality because manufacturers will want to cut costs to maintain their profit margins. I don't know if that's true. There's not a lot of good examples within the US specifically of drug price ceilings. There are some examples like with Mexico where they enacted price ceilings and what they were getting were dry ball tablets. No drug whatsoever. I don't know if that will happen in the US. We'll have to see. Some supply demand shocks. So there was a Cipro anthrax scare in 2001. Letters were mailed containing anthrax to senators. Cipro is a treatment for anthrax poisoning. The fear caused many to seek preemptive treatment and caused a sharp increase in demand. It's also known as a positive demand shock. There was also the influenza shortage in 2004 to 2005. Chiron, a major influenza vaccine supplier, suspended operations. Sudden suspension resulted in too few suppliers and a sharp decrease in supply, and this is a negative supply shock. How much does it cost to produce a drug? So you can't really see it up there. API stands for active pharmaceutical ingredient. That's essentially the drug that's actually being used to treat whatever medical condition. $68,757. Because they're buying in bulk, 20% decrease. The cost of the active pharmaceutical ingredients in 1,000 units, and this example is actually a generic for insulin. They estimated how much it would cost to make a biologic of insulin. So we see the total cost of the vial, $2.14. We also have excipients, drug loss during the process. All in all, $5.32 per 10 mil, 1,000 unit vials. You think that's what we actually spend in the US? So I just put up here glargine. That's also known as Lantus. It's one of the top 10 drugs in the United States. So we see glargine, the price, $68,757. We see estimated price per year is $78 to $108. And the estimated price, $5.32 to $7.38. This chart is actually for glargine. So the actual price per 10 mils, $85.67 is how much the US is actually paying for these drugs for a diabetic patient. But we see the cost to produce it, not that significant, or not as significant. So how much do these drug companies profit? So we see here all drug companies besides largest 25, overall drug companies and largest 25. Notice the very top is the largest 25 drug companies. There is a lot of lobbying in the pharmaceutical industry. We have the PHRMA and the Biotechnology Innovation Organization. Both are top industry lobbyists each year. It was recorded that they spent $179.05 million in 2015 alone. They tend to support Republicans over Democrats in a 3-to-1 ratio. They regularly lobby in response to Medicare bargaining and price negotiating laws. And their most recent lobbying activity was to prevent a law in California from passing in which manufacturers must justify drug price hikes. They really don't want you to see why drugs are so high. And then these are just a list of potential solutions in recent years that have been suggested. These are probably all within the past decade. So open the market to allow global competition, allow substitutions on medications if there's an appropriate generic available, or switching, develop more stringent patent laws, promote and utilize existing laws, cap profits of drug companies, decrease expenses to pharmaceutical industry, forbid brand names from withholding their drug from a potential generic company, enact price ceilings on medications, authorize public insurance to negotiate prices, provide open access to drug comparison data and journal publications, educate physicians on the price of drug. It's actually scary how little physicians know of how much a drug actually costs. Many times, physicians are more cared about the patient and that they're getting the most effective treatment option. They don't always think of the cost behind that though. So something may be very effective and have an outrageous cost, but their thought is, I'm treating the patient in the best possible way. Is it though? And then include the cost of medications into physician payment models. So this has been a more recent one, so that patients can actually see how much the drug costs on that bill, rather than just going to a pharmacy. Because a lot of the problem with pharmacy is they get to see that bill in the form of a copay for their drug. And then utilize the FDA's ability to seize patent rights for our registered drugs. So any drug that was funded or is funded with public tax dollars, the FDA does have the right to seize and produce that drug. To my knowledge, it's never been used though. And it may never be. And then these are just some references.
I know some of you guys are, involved in speech and debate. This is a relevant topic. Other of you guys are just generally interested, whether it's through economics or politics, etc. I know we have plenty of time for questions and answers. Now, having been exposed to that, do we have any questions for Mr. Johns that we'd like to ask at this time?
You seem to express doubt in the beverage model or method of insurance. Why?
So you're talking more about like the Canadian model.
Right.
See, the issue is not so much the beverage model, it's the way they're doing it. So like when they first enacted it, there were a lot of cases of broken bones, for example. There were a lot of cases where they actually had to re-break bones due to wait times before a patient was able to get into a doctor. So it's not that beverage models are bad. I just don't know that they're the most efficient use for patients. And it also depends on the area. So in a high volume area like ours or like Indianapolis, if we were to use a beverage model, then let's say a patient does break a bone. That's all those patients in that area. Versus if they were to go to central Indiana where it's less densely populated and be able to get treated. But people don't want to make that drive, right? They want to go where it's closest to them. And that's a lot of the issue that arises with Canada. That just those long wait times because of funding and a lack of patients wanting to go to other areas.
When I was in college, there was like a hot new job that a lot of my friends went into, at least initially. I actually don't think any of them saw it through. But pharmaceutical sales, that was like the thing. Men and women, a lot of the kids at IU who were going to Kelly for business and maybe didn't get into Kelly, they went into pharmaceutical sales. Can you talk about, like you mentioned it, alluded to it, their role as far as in relationship to the doctors and who they represent and how that arrangement or interaction plays out?
So pharmaceutical drug reps most commonly are employed by the marketing and sales team for an actual drug company. So they typically work for a manufacturer. As far as like their role, a lot of times their education varies a lot. So there are actual drug reps who have a pharmacist education or maybe even a medical doctor. Most commonly the ones I hear are more like a chemistry, a basic biology. A lot of times they do have bachelor's degrees of some sort. It may be in a science-related field, or it may be like the IU Kelley School of Business, a standard business degree. They typically interact with doctors, and what they'll do a lot of times is they'll provide studies, literature to these doctors to try and sway a doctor's opinion into changing to this drug. One of the common ways they do this is just handing samples of their drugs. Many of you may have gone to a doctor and gotten a sample of a drug. It's not uncommon where they'll just give you like a couple days supply, a lotion, a cream, something like that. Doctors really love that because they can just give it directly to a patient to try. And the patient doesn't incur any cost, and a lot of times the doctor-patient relationships improve because there's no cost. And a lot of times they may not even need a full 30 days of supply. Some doctors are okay with giving a 30-day supply in just those alone.
Almost lobbying at the very personal level for specific drugs.
Yeah.
Interesting.
They also don't have to be about this either. If you have questions about pharmacy in general, or Purdue, feel free. Or don't, as Mr. Nelson.
Yeah, it's the proper pronunciation.
Inferior school. Why did I choose an inferior school? So when I was applying to colleges, there were only 3 colleges in Indiana that offered pharmacy. Well, when I was applying, it was actually 2, now it's 3. It was either you go to Butler, you go to Purdue, and now you have the option to go to Manchester. I really wanted to become a pharmacist. My first choice was actually Butler, then I got that bill, and it was like $60,000 versus Purdue that said, okay, we'll charge you about $15,000. Like, yeah, I'm gonna go with the cheaper option. And Butler wasn't even ranked on anything nationally, so Purdue was the better option for pharmacy. Yeah.
Are you planning on going into like producing drugs, like doing